All right, I still haven't gotten word that interpreters have joined us, but I want to go ahead and get started. We have a lot of material to cover, and we can introduce interpreters when they do join, and I'll rely on my folks to give me a heads up in our chat. So first, welcome. Thank you very much for joining us today in the BHA regulatory stakeholder meeting. You can see up in the upper right of your Zoom meeting that you can pin speakers if that's not already done, and when the interpreters join, do the same. You probably heard the recording voice say that this session is being recorded, so we are doing that. We also intend to post the recordings of each one of these virtual meetings on the BHA website. So if you want to go back and review, or you want to share that with someone, perhaps a colleague that wasn't able to join, you can certainly do that. In terms of some other technical kinds of questions, you can put those questions in the chat box for host to respond. And please put your comments on the rule volumes in the question and answer area, and we will either respond in this meeting or denote for further response. If you'd rather provide feedback verbally, we will have several question and answer periods, trying to bake those in after each particular section and also carve out a little bit of time at the end. You can also, during that time, raise your hand if you want to speak up verbally. On behalf of Commissioner Smith, I would like to welcome all of you to this overview of the rule changes from the BHA. My name is Tom Miller. I'm the Division Director of Quality and Standards, and I'll be joined today by several other members of the BHA, each of whom will introduce themselves in their various sections. I'm also going to be doing a little bit of MC work throughout the presentation today, and also covering some of the provider rules themselves. Quick overview of the agenda. We're here to share new and updated rule volumes and get your important input on what is working and what we should change within those rule volumes. Just so you know, we'll have 5 in-person and 4 virtual meetings, all running through the end of October. And then I'll put up the specifics about that timeline here in just a moment. Just so you know, these are different than in previous years' provider rules, because today we're going to talk to you about the 3 rule volumes, and also I will get more specific about those volumes here in just a second. Today we have about 2 hours for this meeting, and again, we're trying to bake in some time for questions after each section and also at the end. First, very high level, what is a rule? In the most basic sense, rules are the state agency's method to implement the law. Those laws frequently require a state agency to develop rules, or in a technical sense, promulgate rule, and in doing so, that state agency's role is to add specificity and clarity to that law. The second part of the slide is that part of promulgation of a rule is to obtain community input and build and refine the rule. And you'll probably remember over the last 18 months or so, if you were part of the provider rule promulgation process, you know how much we value your input and how many changes we've made as a result of that input. So I see that our interpreter, Brenda Howe, has joined us. Thank you very much. Again, it looks like your page is already pinned, but if anybody has any technical questions about that, they can put that in the chat box for the hosts. So I alluded to this just a second ago. Here are the 3 rule volumes in question today. The first are provider rules, which set requirements for licensing, designation, and approval for service agencies. These are the ones you're probably most familiar with, and these can be found at CCR 502-1. You've probably looked that up 100 times on the Secretary of State website. The second are system rules that will describe how BHA sets the vision for the behavioral health system. You will see those at 2 CCR 502-5, and then finally administrative rules that will control how programs and initiatives are accessed, and those exist at 2 CCR 502-6. All that sounds new, but if you go to the Secretary of State's website, you'll see that those volumes already exist. So we're going to be using those section on that website. Whoops. There we go. So just a second ago, I alluded to additional rule feedback opportunities, and that's what you can see here on the slide. Today is our first virtual meeting. We are going to have this and then 3 others, and there is also more detail about how you can participate in engagement opportunities, and you can see our in-person schedule there listed at the top. You are certainly welcome to attend each one of those, but know that we intend to present this same material at each one of the virtual and in-person rule meetings, though probably what's most likely to change are the questions that we get at each and our responses. We are keeping track of each one of those questions, both written and verbal, and that becomes part of our rulemaking packet. And then finally, at the bottom, you can see links on the website for you to ask questions or give additional written testimony. We anticipate, in terms of the last part about the timeline, that we will be going to the State Board of Human Services early next year, and for those rules that the commissioner herself will hear in roughly the same timeline. Whoops, did I skip past one? There we go. So in terms of provider rules, so I'm moving out of my MC duties and a little bit into what are changing within provider rules. This is a top line of what those changes will be. We are doing some technical cleanup with behavioral health entity license. That's the base license, also known as BHE, that has several different endorsement types. Safety net approval, the biggest new category that we introduced last year. Some technical changes and some additions based on interim legislation for our 2765 designation. And then finally, our most substantive change, our controlled substance licensing. Just so you get a sense of the number of chapters that exist in provider rule, these are all of those listed in order. Now, don't worry, we're not going to go through every single one of those like we did last year. Again, this is really technical change for the areas that I just mentioned. Plus, the most substantive change you'll see here at the bottom, that's Chapter 13, which is a new chapter that we didn't cover with last year's provider rule updates, and we'll be going to that in just a minute. And then Chapter 14, which is really just a cut and paste of Recovery Support Services Organization, which we moved from our legacy rules in Chapter 21 to this rule volume, but again, no changes on that particular part. So at this point, I'm very pleased to turn it over to Ryan Mueller, who can introduce himself and then start to go over some of the substantive changes with controlled substances licensing. Thank you very much, and over to you, Ryan.
Thank you so much, Tom. And good morning, everyone. My name is Ryan Mueller, he, him pronouns, State Opioid Treatment Authority with Behavioral Health Administration. And it's my honor to be here today to talk a little bit about some proposed changes we have to controlled substance licensing and OTP care. That's opioid treatment program care, otherwise known as methadone clinic care. Let's see. So just a bit of background before we get started. I'm going to break these slides up into two parts. The first is going to talk a little bit about how we got to the point of proposing a rule change. The second part is going to be about the rule changes proposed themselves. And a disclaimer, we are going to talk a little bit about some things that are heavy in this subject, such as overdose death data. So please take care of yourself as you need to through this portion of discussion. Okay, so this slide is really intended to tell a story of our nation's philosophical holding of opioids in their application of treating opioid use disorder over the last 100 years. It's a bit of a duality. On one side, we regulate and legislate to really restrict access to these medications to the general public. And in some pieces of this history, opioids were actually illegal. They couldn't be used in any way to treat opioid use disorder. On the other side, we have had emerging research, trials, and evidence that demonstrated that methadone was quite effective in reducing withdrawal symptoms and cravings, reducing illicit opioid use, and also reducing chances of death related to opioid use disorder while in treatment. Throughout that time, it's also noted that methadone-related overdose deaths in treatment remained low and flat. This sort of came to a head in the 60s and the 70s when essentially the federal government decided treatment is a good idea, and here's the parameters in which that will happen. The FDA approves methadone for use in a methadone clinic in 1972 with some parameters. They say they define how a person may take medication out of that clinic, and they also define what qualifies a person to get into treatment. These restrictions have echoed throughout the modality over the last 50 years, and they're still in place until we now talk about rule change. So I feel like in the next couple of years, what we're talking about today will probably be one of these bullets in the future presentation. So how do we get to the point of rule change? Really, it was COVID. And just like many other healthcare systems, the methadone modality had to rethink rapidly how it was going to deliver service. And by separating people from the physical treatment space. And as many folks on this call may or may not know, in a methadone clinic, that you're looking at daily waiting in line, direct contact with both patients to patients and patients to providers. And so the regulatory system at the federal level over OTPs, which is SAMHSA, recognized that their rules in place really were impeding this ability. And so they issued a series of flexibilities in 2022 to allow for folks to take medication out of the clinic a little bit more often and allow for telehealth medicine to go into that space. At the state level, we were able to opt into those flexibilities, just as many other states were. Colorado did so almost immediately and have been enjoying these flexibilities for the last 4 years. I would also just like to mention that in 2022, Colorado coordinated with SAMHSA to come up with our own series of flexibilities that we thought would further align us with contemporary OTP practice and improve outcomes in treatment. Part of that was allowing patients to enroll in treatment prior to 1 year of having an opioid use disorder, temporary Saturday clinic closures related to major staffing shortages across our states, and also buprenorphine microdosing associated with, of course, with fentanyl-related opioid use disorder. Okay, so over that 4-year time period where flexibilities were in place at a national level and at a state level, SAMHSA did their research. And what they found during that time period was that by allowing these flexibilities to remain in place, We saw increased retention in service in the OTP setting, increased overall census, improved treatment outcomes, and again, like I mentioned before, stable and low methadone-related overdose deaths. To your right, you see an infographic provided by SAMHSA that sort of tells that story of overdose deaths by drug type and class over the last 10 years, 8 years. That very bottom purple line on that grid represents methadone-related overdose deaths. Again, low and flat through that time period as fentanyl continued to rise. So as SAMHSA essentially hitched these flexibilities to the public health emergency declaration related to COVID, they recognized that, wow, we have really good outcomes related to these flexibilities, and we're also seeing an unwind on the COVID side of discussion. So what are our options? They decided to make permanent these changes in their rule volume. And on April 2nd of 2024, they did just that, expecting OTPs to come into compliance actually later next month, October 8th, 2024. And these are their stated intentions behind those rule changes, just for folks to see, to promote practitioner autonomy, remove stigmatizing language, support patient-centered approaches, and reduce barriers to receiving care. Now, at the state level, we have to ask ourselves, what's the difference between us and federal data? We get it, but Idaho and Florida are not the same. California and Missouri are not the same. So what were the impacts of these flexibilities to us? And here's what we found. This is data provided by CDPHE. And what that was essentially throughout this time period of flexibilities, throughout COVID, throughout the rise of fentanyl, that methadone-related overdose deaths remain low and flat. And also if you go to that infographic on the right, we'll see that just as SAMHSA recorded at a federal level, our state OTP census rose dramatically during this time period of flexibilities, somewhere around 30% over the 4 years between 2020 and 2024. And what we also know is we have a sincere overdose crisis in our state, recording at least 1,800 overdose deaths per year at an unacceptable level. And what we recognize in this consideration for rule change is that if we don't do anything to change the way we are handling the situation, we can expect very similar outcomes in the future, which I think most people on this call would agree are not acceptable. And we also recognize that while folks typically do well in methadone treatments, access to methadone treatment remains a very serious set of barriers in place that don't allow folks to get to it. Generally, you have to live in a suburban or an urban setting where OTPs exist. Rural and frontier communities generally have fallen outside of this treatment access in the past. We think that rule change is something that might have an impact on this in the future. I could talk a little bit more about that as the presentation goes on. But essentially, with this information, we decided it's time for us to make some rule changes of our own. And what were our intentions behind these rule changes? They're pretty clear. Realignment with SAMHSA's new permanent flexibilities, increasing access to life-saving medication, improving quality of care, reducing overall community harm, and reducing stigma and increasing trust within the system. So let's get into the rules. Okay, so here's just a glossary of terms for folks. I know we love our acronyms at the State Department, don't we? But the biggest ones I think to focus on, OTP, if I say that over and over again, that's opioid treatment program, it's methadone clinic. CSL is a controlled substance license. That's a BHA license that allows you to practice methadone care. Okay, so just a bit of cleanup here. We wanted to clarify in the rule set that a controlled substance license must also meet BHE standards. You can't have a CSL, you can't have a controlled substance license, and you can't have a methadone clinic license if you are also not have registered as a BHE. You must have that. That license cannot extend beyond the BHE licensing term. Additionally, the BHA will not issue a third provisional controlled substance license, very similar to the BHE. Also, a little bit of clarification as to what qualifies you as requiring a controlled substance license, and that is that you store, stock, controlled substance supply for the purpose of treating a substance use disorder or withdrawal from a substance use disorder. About half of those licenses are methadone clinics, which automatically require you to have a CSL, and the other half, roughly, are withdrawal management support systems that store stock controlled substances. So just to clarify again, if you are prescribing medication for treating an opioid use disorder, that does not necessarily qualify you for a CSL. And the last piece of clarification is we use terms like physician, physician assistant, and nurse practitioner within the rule set sort of repeatedly, and we change that to qualified practitioner to recognize other prescriptive authorities that are continuing to enter our clinical workspace that can do this work quite well. I recognize I'm totally breaking a rule in presentations, and that is don't use a lot of words. Unfortunately, this is a presentation about a lot of words. We're giving you the real rule in front of you, and I'll walk you through it as humanly kindly as I can here. But the biggest changes we think have occurred on this rule volume are improved access and improved quality of care. Everyone that goes into a methadone clinic, an OTP, is required to partake in a medical evaluation and a physical exam. And at this moment, we are essentially proposing, along with alignment with SAMHSA, that folks can receive a medical evaluation or a physical examination through alternative means. So provided at a hospital, at a primary care setting, so long as that OTP medical director or practitioner is able to review documentation and approve that that is the information they need in order to qualify you to get into service. Also allows for medical evaluations and physicals to be performed in a telemedicine setting. So remember when I said earlier that access has been genuinely restricted to urban and suburban settings? Well, this allows OTPs to expand their reach into rural and frontier communities, utilizing through telemedicine providers that exist maybe on the Front Range, but are not going to be found in those mountain towns. So giving people increased access to life-saving medication. Another piece of this is expanding upon the requirement that someone must have a physiological dependence on an opioid as a criteria to enter service. We've expanded upon that to essentially include folks dealing with an active, moderate to severe opioid use disorder, are in remission, or are at high risk of recurrence or overdose. So that spectrum of what should qualify you to receive this medication is being left more in the hands of the folks providing the care and the patients wishing to enroll in that care. Counseling services have changed a little bit. We've received a lot of feedback over the years at BHA and OBH from OTPs and other folks asking what sort of counseling services really make sense in this sort of setting. And fortuitously, SAMHSA has been really declarative about what sort of counseling requirements need to be in these spaces. And part of that is focusing on vocation and other service offerings, dealing with communicable disease monitoring, and really filling that void post-recovery. And so we borrowed that language from SAMHSA and have applied that to our rule set. Another major shift in the counseling side of OTP care is the fact that we are now proposing that refusal of counseling must not preclude someone from access to medications for opioid use disorder or methadone. So essentially, it's kind of the living act of meeting patients where they're at. Another piece of change to improved access is the fact that we now say that OTP shall provide alternatives to admission denial due to lack of government-issued photo ID. There is no rule or law that requires folks to have a state-issued, not a valid government-issued ID to enter services. But over the last several decades, that is exactly how OTPs have interpreted that space. And as a result, we have seen a fair amount of folks being denied access to life-saving services because they don't have an ID. And as many folks on this call recognize, folks that suffer with issues that might move them out of housing stability, they find that their possessions are oftentimes stolen or misplaced. And to get a new photo ID in a short amount of time is unreasonable. And during that time period, access to medication should not be a concern for them. And the last piece of this is including language to require OTPs to provide special services for pregnant patients and folks that requiring prenatal care and other sex-specific services. So I can get into details of that if you all have questions, but I want to make sure that we have time for all the other rule changes. So we're going to keep on moving forward. Going really now to, I'd say the biggest piece of this change, the next two slides are going to be talking about what qualifies someone to take medication out of a clinic, and then what's the frequency and volume that medication can be taken out of the clinic. So within this first portion, the graphic on the left indicates the previous language that was used to describe that requirement. And then can you all see the screen? We can see it now. Great. So the graph on the left is essentially demonstrating, hey, these are the requirements that we've historically said you have to meet in order to get a take home. And the graph on the right indicates this is the new language. One piece I just want to mention about this list of requirements, when the FDA and others came up with this set of requirements way back in the 70s, it was intended to operate sort of like contingency management. And that is, I will give you a reward, and in return, you will partake in pro-social behaviors. We'll modify your behavior in that sort of way. Contingency management is still a very effective behavioral health strategy in treating things like substance use disorder. But what was unintended in that space was to say, if I remove that reward, if I remove that convenience, that ability for you to take medications out of a clinic, what I'm also introducing is a punishment. I'm taking away your time and your freedom and your ability to access medications every day. If, say, you got to work in the morning and you can't come into a clinic more than 3 times a week or 5 times a week. And what we saw from this nationally and at a state level is folks, when they lose their phases as a result of not meeting these requirements, would drop out of treatment and become far less stable doing so. So this first indicator here, most recent toxicology screen is negative. That was the previous requirement. We have moved that to an absence of an active substance use disorder, other physical or behavioral health conditions that may increase the risk of individual harm as it relates to the potential for overdose or the ability to function safely. So this allows the provider to use discretion and judgment in determining what really makes sense for that patient. And it really gets to the heart of the matter. Additionally, we see highlighted on the left side is no known recent criminal activity. And again, that activity might be concerning if it relates to things like diversion of medication, but really that's all we're worried about. So we changed that language on the right side to absence of known recent diversion activities. So again, these changes remove stigmatic criminal components to requirements, considers the SUD spectrum beyond just toxicology, and promotes trust in prescriber judgment and patient reporting. Okay, going to the next slide. So on the left side, essentially, those phasing structures are defined at the federal level, or have been over the last, again, 50 years. And that tells you how long you have to be in treatments in order to receive X amount of medications. Now going over to the right side, we see that this is the new federal standard, and the new standard we wish to echo in our state rules. One example of that is on the left side, phase 1, that's your first phase you would receive in treatments, that you would get a dose on Sundays and then 1 additional take home per week. Well, you had to be in treatment for 90 consecutive days, meeting all those additional requirements in order to receive that additional 1 take home. So this person, imagine, would be showing up in the clinic every single day, except Sunday, for that first 90 days, after which they would get 1 additional take home. So on and so forth, all the way down to phase 6. You have to be in treatment for 2 solid years, and then you're able to take out of the clinic at least 30 doses at a time. Well, going to the new standard, essentially what they have done is removed the time in treatment requirement. And I'll read them, just the sort of the top bold bullets, that during the first 14 calendar days of treatment, take-home doses are limited to a 7-day supply. So within that first 14 days, you're able to receive up to 7 take-homes. From 15 calendar days of treatment onward, you are limited to 14 days. And from 31 calendar days of treatment, take-homes are provided at 28 days or less. This doesn't necessarily mean that a prescriber and a patient will conclude that this is the right take-home course for them, but this is what is allowed within those time parameters. So again, this removes the time and treatment requirement. It removes the concept of structured phasing. It does rely on prescriber judgment and also forces the system to individualize patient care and patient needs. So the counterbalance to allowing more medication to leave the clinics, which again, I'll just remind folks, has been going on for the past 4 years under our flexibilities from both SAMHSA and state regulations around take-homes, but this is a proposal to make these more permanent changes. We've increased and better defined requirements within diversion and central registry control. So every OTP shall maintain a current diversion control plan, which assigns responsibility to the OTP medical director and administrative staff to monitor things like program environment, dosing, take-home doses, take-home dose callbacks, which we can talk about a little bit if you'd like, prevention of multiple program enrollment, so making sure that folks are not enrolling in multiple methadone clinics at once, and also misuse of prescription medications. In the event of take-home medication theft, loss, or diversion, so let's say that someone misplaces their methadone, or someone leaves it on a bus, or gets it stolen, or admits like, listen, I'm having a hard time. I took more than I should have. Well, those take-home dose replacements shall not be provided until documented review and approval is given by the OTP medical director on a case-by-case basis. In-person dosing shall be continued in the event of take-home medication theft, loss, or diversion, as we recognize that access to life-saving medications are crucial, and we do not wish to disrupt that. Also, we require now that medical directors shall ensure that their OTPs make documented efforts to outreach service recipients who have missed 3 or more consecutive doses. And the last piece of preventative measures that are new, this is related really to the fact that we are now celebrating our state's first methadone opioid treatment units and methadone mobile opioid treatment units in the states, that these units operate under the license of an OTP and therefore do not require a separate account in central registry, but ultimately the OTPs are responsible for making sure that those patients are enrolled effectively in their programming and that medication error across that spectrum of service delivery is reduced to a minimum. Okay, so I've just got a couple of slides left, but we're going to talk a little bit about how our proposed rules are improving on harm reduction. So the first is just sort of defining the parameters, our jurisdiction of rule. And at the federal level, at 1306.07, our rules are intended to remind folks that among the abilities that folks have to serve people with opioids that are dealing with withdrawal or opioid use disorder in medical settings, hospitals, emergency departments, clinics are allowed to provide 3-day supplies of methadone, dispensed methadone or buprenorphine for the purpose of treating those disorders. Now, they can't provide anything additional to that. And so obviously the real key to that is an ER might induct someone on methadone or continue their dosing, but really refer them to a methadone clinic. But what that law also talks about is folks' ability to treat secondarily an opioid use disorder while someone is receiving medical services for a primary medical diagnosis. Let's say that someone goes into a hospital, they're in an inpatient setting, and they're being treated for a blood infection or a broken leg, and they also have an opioid use disorder. Well, that hospital registered with the DEA is able to dispense methadone or buprenorphine for the purpose of treating withdrawal or opioid use disorder during that time period. And so really, this is outside of our rule set, but we want to clarify and encourage folks to meet people where they're at in order for these folks to receive care when they need it. Okay, so moving on to the prescribing, dispensing, and administration of approved controlled substances. We really wanted to remind OTPs that they must make a good faith effort documented effort to obtain appropriate consents and coordinate transition of care to nearby MOUD treatment or other applicable services to reduce the risk of withdrawal and harm. That's when they have to administratively discharge a person from services. And when that transfer effort is unsuccessful, OTP shall notify and coordinate with the SOTA, that's my position in my office, before providing a safe medical taper due to inability or unwillingness to pay. Because we do not want to see inability or unwillingness to pay to be a preventative factor from someone staying in service. We've also removed a couple of pieces of language that we do believe support harm reduction initiatives, and that is Colorado. I'm going to give us a little toot. We were ahead of this one, but SAMHSA removed their 1-year OUD requirement to enter into OTP care, and we will celebrate that removal too by officially removing it from our state rules. Additionally, removing the requirements that individuals under the age of 18 shall have at least 2 unsuccessful attempts at short-term supervised withdrawal or drug-free treatment documented within a 12-month period in order to enter service. It's really up to the patient and the prescriber to make the best decision for that patient, and we intend to put that decision-making authority back where it belongs. Additionally, we've removed things like a requirement for folks to check for dermatologic indication of opioid use. There are many better ways to find out where a person's at in their recovery or lack thereof, including the spoken words of a patient that's enrolling into treatment and trusting what they have to say about their own body and their recovery. So we're leaning into that. Take-home dose protocols. So OTPs will offer either directly or through prescription opioid antagonists, such as Narcan or naloxone, for all individuals receiving methadone or medication take-home doses. This is the last slide for this section. And really, this is about stigma reduction, taking away things that we recognize might be pretty harmful or reinforcing of some old non-contemporary ideas of SUD in practice. We required previously that methadone programs would require patients to physically bring in medication prescriptions so that their doctors could determine if those medications were appropriate for continued use of that patient. Really, that's kind of a scary concept that the OTP provider would be required to make decisions for a person's medical care outside of OTP practice. We didn't think that that was a safe practice to continue, so we removed it. We are still keeping in place the requirement for an OTP to continue to check the prescription drug monitoring program to screen for contraindicated controlled substance prescriptions that a person might be on and make decisions from that point forward. Within toxicology screens and urine screens, we removed the word privilege from the rule set. This is a word that we've echoed for decades, indicating that a person and their ability to receive medications outside of a treatment setting, take-homes, was a privilege, when really we think that it's just evidence-based practice and it's a right, and they should be able to do it when they qualify. We've also replaced the word abuse with the word misuse throughout the CSL rule set. And lastly, we've required now agencies to consider how they incorporate harm reduction and trauma-informed practices and respect for gender identity of the individuals being screened in that process. So that concludes sort of the higher level changes that we are making to the CSL rule set, and I'm absolutely happy to open it up to questions that people may have.
Ryan, first let me say thank you very much for that. Every time I hear you present, I feel lucky personally, but also on behalf of BHA and everyone in Colorado that we have a person with your level of understanding and skill working here and doing this. With that very heartfelt thanks to you said, let's take a couple of minutes and see if there are questions from our audience for you and controlled substance license in particular.
Thank you, Tom. This is Marina. Ryan, I think we have 2 questions, and I think they're mostly on the data that you presented. I will go ahead with question number 1, and the question is, are there more metrics of the demographics for overdoses, such as homelessness, community youth, etc.?
That's a great question, Marina, and I would have to hope that there would be more information. That's not information that we collect at BHA's level. we've borrowed the data that we provided today from the Colorado Public Health Division, CDPHE. So I think this is a question that we could probably better answer by involving the data experts within that department.
Thank you, Ryan. And the second question is, and I came in about 15 minutes ago, so I'm not sure exactly on which point of your presentation, but the question is, does this include other drugs like cocaine?
Sorry, Marina, can I ask for the first part of that question again? Does what involve also other drugs like cocaine?
Does this include other drugs like cocaine? So again, I'm not sure exactly at which point of your presentation the question came in.
I wonder if the question, and I don't mean to speak for whoever asked it, but the perhaps monitoring for overdose deaths, either at the state or the federal level. And so the slide that dealt with overdose deaths in the state of Colorado, that was opioid specific. Now talking about at the federal level, that was not. That involved, if you want me to go back in my slides, I can, but monitoring overdose deaths from January 2015 all the way through 2023. That included all drug types. I don't know if that was helpful in answering the question or not, but.
Thank you, Ryan. I don't have any other questions here in the chat or in the Q&A.
Thank you very much, Marina. Anybody that wants to raise a hand and ask a question verbally at this point?
I don't see any, but maybe people are typing them furiously.
Okay.
We also dropped a link to the feedback form in the chat as well. We can repost that just to bring it up top, and maybe people will take opportunity to engage there.
Got it. Fantastic, and thank you for that information again for everyone. We're going to do a few minutes of questions after each section, and then if time allows, carve out hopefully a few more minutes at the very end, and then folks can ask questions that they didn't get to during the presentation, or other kinds of questions perhaps that don't even fit within the presentation. All right, I think we can move to the next slide then. So it's back to me, and I'm going to cover some of the proposed changes within provider rules. Again, this is one of the 3 volumes. This one concerns 2 CCR 502. And again, Tom Miller, I am the Division Director for Quality and Standards. He, him, his are my pronouns. We are going to be talking again about chapters 1 through 12. Thanks again to Ryan for going over CSL rules. But first, we're going to talk about really what technical cleanup means. First, we're talking about technical changes that really concern citation errors and grammatical errors. And I'll tell you, I'm embarrassed. We had so many people reviewing the rules from last time around, but there still were a few citation and grammatical errors. So I think we've caught all of those this time. So we're going to do that very basic cleanup. More importantly, we're going to do some changes to add clarity to rule sections, just a few additional words here and there to define what the meaning of that particular section is. I'll go over some of those. Clean up inconsistencies within our own rules and also with other state departments' rules, particularly in situations where there's dual licensure or a license and a designation. And then a couple of areas that I'm pleased to say that we've been able to reduce some administrative burden, but not, we believe, impacting the safety of those receiving services. I'll cover a few of those. And then, of course, there's been some interim legislative changes that I'll get to in just a moment. So the first are the things that we've added to the rules. The first is in the definitions. This is at 1.2. We didn't previously define the term owner. So we are taking that definition from the Colorado Department of Public Health and Environment, their Chapter 2 rule at 6 CCR, and we're adding that part in. So back to our rules in Chapter 2, 2.19 and 2.43.3. This is a section where we get more specific in terms of an endorsement being added or removed and not affecting the agency's overall behavioral health entity license. We think that this is a bit of an administrative burden improvement and also a due process improvement where potential adverse action against an endorsement doesn't affect an overall license. And you'll remember at the beginning of my section earlier this morning where I talked about the behavioral health entity license being an umbrella type license with endorsements being plugged in and out of that endorsement type. So that's a real advantage, and we've made that more clear here in this rule. Moving on to 8.2.1, the children and family standards. This change makes it more clear that FBI background checks will apply to all employees, and in particular, those current employees, not just employees that are joining after the rule was made effective. At 11.9.6.1, we are proposing a change that will allow for, and this goes back to the dual licensure that I mentioned just a second ago, for those facilities that may have a license from the Colorado Department of Public Health and Environment, and in particular, a designation from BHA, to be able to use the requirements and dimensions for restraint and seclusion rooms from the CDPHE regs, and that will qualify for BHA requirements. So again, another one of those areas where we believe that has an advantage in terms of administrative burden. Let's see, moving on to 11.10.1.d. We are proposing the addition of language to allow for minors to receive electroconvulsive therapy with a parent or guardian consent with 2 psychiatrists treatment recommendation. And this is one of those legislative changes that I mentioned earlier, because this is done to align with the requirements of House Bill 24-1471. Again, another one in that category, 11.10.1.I, we are proposing the addition of language to clarify for age of consent changes, and this is for mental health services and 2765 services to also align with that new statute in Senate Bill 24117. And then I believe finally for the addition section 12.6.1.k allows for providers to align their license and approval dates. The issue here being if a provider has more than one license type or more than one license and designation type, our rules say that we can shorten a particular approval cycle to align so that we have aligned renewal periods, which means an agency deals with us one fewer time. Again, another one of those practical kind of changes that we hope help with administrative burden. I think I lost my little forward button, so if somebody could help me with moving to the next slide. There we go, on to amended language changes. So these aren't necessarily additions or deletions. These are things that we're just modifying. The first of those is 2.5J, which is in the BHE standards. This change is to reduce administrative burden on the agency who may choose to reduce training requirements for contracted personnel to just those trainings related to health, safety, welfare of individuals receiving services. The plain language here is that if an agency contracts with someone or an agency to do a particular service, that they only need do training that speaks to health, safety, welfare, rather than all the other training requirements that exist for a behavioral health entity licensee. The second in the amended language section is at 2.10.A.6, again, BHA standards. This is to reduce provider confusion and add clarity to when a discharge is to be completed, specifically that these are required for all individuals upon discharge. That's one of the frequent technical assistance questions that we received. I'm still missing my arrow, so if people want to help me, thank you very much again.
I will do that for you, Tom.
I don't know if it's me on my end, but regardless, Marina, thank you for your help.
No problem.
The last section here in terms of the changes that we have are the deletions, things that we are removing from our rule. I'm going to skip reading all the alphanumeric rule here and just get to that. This is the last several sections in rule where we are removing the 25% ratio for personnel. This is something that we heard over the last year. So this operates in two ways. One, it gives more discretion to the licensed or designated facility to be able to determine what appropriate ratios are, and then also gives discretion to the individually licensed professional who has a license from DORA to make those determinations. So again, BHA isn't going to have an additional standard that exists in our rule. In the safety net with crisis stabilization unit and acute treatment units known as CSUs and ATUs, we have struck this requirement from comprehensive services. This aligns with healthcare policy and financing and the way they do billing reimbursement for that. So hopefully that is additional provider burden reduction and alignment with our sister department. And somewhat along the same lines, finally at 12.6.1F, we are removing the requirement for a certificate of compliance, which is what a facility has to get when it gets a fire inspection from the Department of Public Safety in order to receive an approval. We have taken that requirement out of safety net approval. Now, while we consider that also a reduction in administrative burden, keep in mind that that requirement still exists when a facility has a behavioral health entity license. So said another way, the COC attaches to the behavioral health entity license. Believe that's it for the modifications, additions, and deletions. Let's move to the next slide. So same with Ryan Mueller's presentation. If we can take perhaps a few questions now just on that particular area that I just presented before we move on to other sections.
I don't have any questions, but maybe give a minute for people to type them or raise their hand if they would like to voice the question.
Thank you very much, Marina. While people are thinking about that or perhaps typing furiously, I will say that provider rules, having gone through its major revision last year, and really we're following our pledge that we're always in a period of community engagement. A lot of the changes that I just went over are a result of what we've heard from all of you and a broader set of community members. So we hope that you're finding these changes responsive to questions or concerns that you have raised. And again, this is an ongoing iterative rule process. So it doesn't end with this one. We continue as we move forward with each one of these engagement opportunities and back to the board. Not hearing any additional questions, I think we can move on to the next section. And at this point, I'm very pleased to turn it over to my esteemed colleague, Ryan Templeton, to cover system rules. Ryan, if you'd introduce yourself.
Thanks, Tom. Welcome, everyone. Ryan Templeton, Policy and External Affairs Division Director with the Behavioral Health Administration. I'm here to talk about system rules. You may be asking yourself, system rules, what are those? System rules currently exist in a way, right? There's currently a rule volume that BHA owns that's 2 CCR 502-5, not to be confused with what Ryan Mueller and Tom just went through related to the provider rules that are those 2 CCR 502-1. So a different rule volume that serves a different purpose. So with that, I also do not have access to the controls. So if we move to the next one, like I had said, system rules are not new. There's currently programmatic specific rules in there. This rule volume is awarding gambling addiction grants and addiction counselor training requirements. Those have been in this rule volume for quite some time. And what we're doing within this rule volume is adding a new chapter 1. So that is all new content related to our behavioral health system standards. So behavioral health system standards are really how BHA is explaining our behavioral health system, our service continuum, how we establish service accessibility requirements, and ultimately this is how we allow for a reference point for how we align behavioral health across systems. Very different from how Director Miller had talked about provider rules. These rules do not have a specific entity that is responsible for putting these rules into effect. These are BHA specific. Here's how we share our vision of where we're going with behavioral health. So with the next slide, the Y system rules, the authority and the applicability of these. The Behavioral Health Commissioner, that is Commissioner Smith, has the authority per statute to lead and develop Colorado's vision and strategy for behavioral health for children, youth, and adults. So this is that foundational piece when the Behavioral Health Administration was created in 2022, that, hey, the commissioner has that authority to be that entity or that individual responsible for the system. Part of creating the BHA, it allowed the commissioner to adopt rules directly. So these rules, system rules that currently exist in this rule volume, go to a rulemaking hearing that is, these rules are adopted by the commissioner. So it does not go through the traditional State Board of Human Services adoption, but it still goes through a rulemaking hearing that BHA staff will present to the commissioner directly in a public meeting that you can attend in person and provide testimony at, for or against the rules, that the commissioner then is the entity that adopts them directly. That is allowed per statute as well. And then ultimately, the foundation piece for this is that the BHA is responsible for establishing a comprehensive and standardized behavioral health safety net system. So this and this chapter 1 of this rule volume that is new is really setting that foundation for where BHA begins to establish what that behavioral health system is. So if we move to the next slide, kind of with a lot of rule volumes, it really starts with definitions. Definitions, there's 6 definitions in there that hopefully look familiar, right? Behavioral Health Administration, that's us, that's BHA. We also reference provider rules. That's Director Miller's rules that he just went through those updates for, because we have an incorporation by reference where it's when we explain some types of services, we reference back to what is already included in provider rules. We do not want to try to duplicate rules across volumes. So if it is a provider specific rule, we're just trying to reference back to where those rules actually live. Behavioral health administrative service population is a new definition that's trying to set the framework for how BHA utilizes BHA funding to drive and pay for quality and access to quality behavioral health services. So really starting to think about how is BHA's funding framework starting to take shape. And then also, hopefully everyone knows about the BASOs, or the Behavioral Health Administrative Service Organizations, that are in those 4 regions across Colorado. And then also 2 other definitions related to behavioral health safety net services, which is a statutorily defined term, as well as emergency and crisis behavioral health services, which is part of a foundational piece more to provider rules. We just wanted to make sure that those are available within this rule volume to add additional context to the sections coming up. So within the next part is the framework for, if we can move to the next slide, is the funding framework. Broken this section, the chapter 1, subpart 3 there, that's the 1.3 in this rule volume, is BHA service funding framework. It's first part, what BHA funding pays for. BHA is there to pay for availability and timely access to quality behavioral health services. We added a piece in there about we want to make sure that access to quality and timely behavioral health services, we will support that by all means necessary, including but not limited to paying copays and deductibles for behavioral health services rendered. There is an allowance per statute for behavioral health services or mental health services specifically to have third-party payer pay those for individuals with insurance. So we're trying to really lean heavy into, hey, let's try to make sure that there is access for all people, including individuals with insurance or folks that are underinsured and whatnot, as that is also a statutory requirement of us as well. Part B and C here is how we start to address other types of populations throughout the state. We cannot provide our framework without first getting the community to help us identify what are priority populations in communities, and then how do we influence what service delivery for those priority populations exists. So this is starting to set the foundation for how we engage with community to make sure that we design a system and for the people within communities with the voice of the community. And then also kind of the same piece with subpart C there is there's regional subcommittees that are required per statute. Law requires the Behavioral Health Administrative Service Organizations to create regional subcommittees. We are putting in this rule volume that those regional subcommittees, we need them to identify and influence the funding for the underserved communities. We should not be in Denver Metro deciding what are the underserved communities across all of Colorado. We need those communities to help us identify what that looks like and then how we can target specific funding to meet the needs of community. So that's the first part. It may look like there's not a whole lot in there, but that really is setting the framework for how we're trying to establish what funding at BHA pays for. The next piece, we go into the subpart 4 in this chapter 1 of the 2 CCR 502-5 is our network adequacy standards. BHA statutorily, again, is required to establish and assess what types of behavioral health services are provided on a community, regional, and statewide basis. Statute does not define for BHA what community is, it does not define what region is, and it does not define what statewide is. Moving backwards, I think we can probably all agree statewide covers all of Colorado. There are 2 types of services that we have identified as being statewide. That's our 988 crisis hotline and the services provided by our 2 state hospitals, the state hospital in Pueblo and the state hospital at Fort Logan. Those are the 2 statewide services. And then moving back up, regional safety net is those behavioral health administrative service organizations, or BASOs. Those are those 4 regions across the state. There are services that are specific to those that are more regional. And part of this is we're not setting specific requirements for the BASOs, but we're saying that regional service delivery should be these things. That includes stuff like, get here, walk-in crisis services, mobile crisis services, hospital alternative services, which are like acute treatment units and crisis stabilization services, crisis respite services, and seeing our ALS interpreter, I will slow down a little bit here. Withdrawal management services, behavioral health residential services, and behavioral health inpatient services. Even though we're saying that these are regional services, it does not mean that it's only one type of each one of those services in each region. That is how we're utilizing this rule volume to help us use this as a reference point to align systems. We're align systems with healthcare policy and finance, align systems with the Division of Insurance, align systems with CDPHE that runs behavioral health programs as well. So this is our foundational piece to get to what services are we actually talking about on a regional level. And then moving back up to community safety net services, those are us now defining what is community. We, in this first round of this first draft, we are saying community means a 5-county identified structure where there's large metro counties, micro counties, rural counties, and counties with extreme access considerations. Hopefully these aren't surprising because healthcare policy and financing through their regional accountable entities or their RAIs are utilizing the exact same thing. And this is us trying to make sure that we have a streamlined approach no matter where you or how you receive behavioral health services, that it should be accessible across systems. So those are services which would include things like outreach, education and engagement, the integrated care, the mental health and substance use disorder outpatient services, high intensity outpatient services, recovery supports, though, as well as care coordination and screening and assessment and outpatient competency restorations. Those are the types of safety net services that would be, that we are saying should be available to communities, and communities being those county specific classifications. Our last section in this rule volume is care coordination, system-wide care coordination related activities. We are saying at BHA that Colorado's behavioral health system must have the ability to respond to inquiries related to where and how to access any type of behavioral health safety net services, right? That is a pretty large thing right there. But yes, there is a foundational piece built in through all of Colorado law of how people access services and make sure that there aren't gaps and people aren't falling through the cracks, which is part of our whole system has to come together to establish a care coordination infrastructure. B, we have care navigators and a credentialing program at the Behavioral Health Administration, and those credential navigators per statute must be available at all access points within Colorado's behavioral health system. And then C is if there's care coordination that is administered specifically by providers. Tom's rule volume, that BHA provider rule volume 2 CCR 502-1, specifically chapter 12, has specific provider initiated care coordination requirements. We are not repeating those provider specific requirements in this rule volume, as that is the other rule volume. So yep, it's not the hundreds of pages of rules that are the provider rules. This is currently a 9-page draft. With that, what sort of questions can I answer?
Thank you very much, Ryan. I think people are familiar with provider rules. They've heard me and other folks in the Quality and Standards Division talk a lot, particularly over the last year, but this is a tremendously exciting new area for behavioral health administration, and I think in a lot of ways helps us fulfill the promise that its organic statute created when BHA was first formed. So thank you for going over that. I think this, in addition to what Matt will cover for us next, is really part of that larger mission of BHA. But with that, do audience members have questions for Ryan Templeton and that particular section of?
I don't have any. Oh, I think I did just get one. 1 second. I do have a question that just came in, and I will read it out loud. And the question is, with those rules, how are you identifying the need for child and young adult services?
Yep, fantastic question. We have built into each one of the sections a children, youth and family specific, as well as a how we are identifying other continuums like justice involved as part of this process. This is where this is, as utilizing or stealing this from Tom, an iterative process within this rule volume as well. This is really just our first step in what this chapter 1 of this volume is. We need the community, we need providers, we need individuals with lived experience, we need county commissioners to help us identify what services are specifically needed for kids. I know we have a children's implementation plan. Part of this building the structure of this rule volume is how we are going to implement some of the provisions within that plan, and really, like Tom said, really act on what was created for BHA to do. We have references about a KIDS system in there that includes a similar approach and model to how community, region, and statewide is being delivered, and it aligns with those services, even though it's not the exact same service provider for each of those services. It could be part of creating BOSSOs, part of creating their regional accountable entities through HICPUF is making sure that there is a network that includes both adult services, older adult services, as well as children and youth services along a full continuum that is meeting specific needs of those populations. So look forward to continuing to have those types of conversations as we continue to routinely update this rule volume as well, as this is really just that first step of getting it out there.
Thanks, Ryan. Love the question. Appreciate that response. What else do we have, Marina?
I don't have anything else.
Thank you for that. So with that, let's move on to the administrative rules, and pleased to turn it over to Matt to introduce himself and take us away.
Yeah, good afternoon, Matt Holtman, he, him. I am the intergovernmental and liaison for BHA. So administrative rules, again, these are separate from the first 2 rule packages, and again, a little bit shorter than the first 2 sections. And so we will be going over just the changes to chapter 2 of this section. And so administrative rules really are the requirements for certain programs or certain initiatives and how those programs are applied and how they are accessed. One of the pieces around this section is that we will be going to state boards as part of this rule writing and developmental process, right? So we will be doing that. In this section also, it's focused on technical changes. We are fulfilling all of the requirements laid forth in House Bill 241038. There are also some technical changes here around our BOSSOs. And again, BHA is going to continue to collaborate with communities and county partners as we bolster this section. But really, this is the beginning of getting the infrastructure in rule, especially when it comes to system of care. So the next section within chapter 2 after the authority is our definitions section. And we spent a considerable amount of time making sure that we had a consistent set of definitions that reflected the work in either other state departments or nationally while we use these terms that have been normalized or the colloquial terms. We really wanted to make sure that we had clear definitions of the populations we were talking about or the tools we were implementing. So it's very specific to serious emotional disturbances. You will see a tie directly to a similar definition within our Medicaid partners definition of children with serious emotional disturbances. You'll also see it tied to the Colorado Department of Education's what they need for the IDEA Act. So we wanted to make sure that we were using the same definition across all state agencies. We did define the CANS tool in here also. Complex trauma, that was a definition that we looked across the country and NIH to make sure that our definition again reflected what is happening in other places in the country. And then we defined standardized assessment. For those familiar, this is a combination of the CANS and other decision-making tools, but really wanted to set these two terms apart, which is why they're defined separately. So we move forward to subsection 3 within chapter 2. This is a section specifically called out in House Bill 24-1038. This is determining eligibility. And so we refer back to our standardized assessment, the definition right before this, in what is the standardized assessment, who can determine eligibility using the standardized assessment, and how and when it can be used. So we list all of those pieces there. The second piece of this is, now that we know how we're going to determine eligibility, who can be eligible. The big piece here is really defining that it is anyone under the age of 21 and determined eligible with that standardized assessment. Now, they may also, you'll see in part 3 here, they may also have some of these other complicating issues or criteria they may meet, and that necessarily won't preclude them from getting any services, but it may dictate what services they're eligible for, because they are very specific. So we go through all of those in this section. Again, I know this was, we could have spent more time here for system of care, and we wanted to make sure that we really engaged our communities and other state agencies as we fully develop and flesh out what a system of care is going to look like in Colorado, and wanted to make sure that our rules did not get too far ahead of what Colorado system of care is going to look like. So I do imagine we will be coming back to what this looks like, at least yearly reviews. And then lastly, as we look at our providers, understanding that BHA does not license all residential treatment providers, but aligning, again, our work similar to earlier sections of this rule with our Medicaid folks at HCPF and CDHS, here really aligning with our CDHS partners who do license many residential treatment providers. There was a specific call out for system of care around cultural competency. And we wanted to make sure that independent of who's licensing these facilities, that component was so critical for all of our youth that it was in our rule section also. And then to be non-duplicative, we wanted to make sure that all training was located in one area or focused in one place. And so again, we talk about the Residential Care Provider Training Academy that is currently up and running with our partners at CDHS. So I feel like I went through that fast, and I also want to make sure that that we're just understanding that there is more in the future, but we wanted to lay this out now, get it in rule now for comments and feedback. So I will take questions or comments at this time.
And while people are composing their questions, Matt, I'd just like to thank you for that presentation. I mentioned a little bit earlier about Ryan Mueller and Ryan Templeton. BHA is also lucky to have you, and thank you for bringing all your skill and expertise to bear on another new area for BHA. We and Colorado citizens are better off for your presence. Thank you. And so, Marina, I think with that, I interrupted you. Were you going to go through some questions directly for Matt's portion of the presentation?
I don't currently have any questions. I had one question that then the author then said was answered by one of your slides, Matt. So good job answering the questions as they're coming. So I don't have anything in the chat, and we don't have anything in the Q&A, but I do see that we have someone with their hand up. So we will go and have Jamie go and ask her question.
Perfect, thank you.
Hi, Matt. Good to see you. Thank you for this. I was just reviewing the requirements of 1038 as it relates to the rules and the proposed rules that were due. And it looks like these rules are just meeting the letter of the law, which I appreciate. And I do also appreciate the fact that you said that we're going to be doing more work on these rules moving forward. I guess I was wondering, what is the timeline for that additional work? Do we have anything set for us to look forward to so we can kind of fill in the blank with additional specificity around what you presented today? Thank you.
Yeah, thank you, Jamie. So yes, we know our Medicaid partners are working on fleshing out what a system of care can look like for them. We are also contracting with a national expert to see what a system of care can look like for Colorado for BHA. And we want to make sure that as all state agencies, we're moving together in those efforts. So we don't want to get too far ahead of either one of those. But I would imagine we're looking at in the next year to have additional comments, additional rule or policies set out for community partners, county partners to react to, add to, and get more feedback on. This is the direction in which we're committed to go, and we're definitely going to need your help to make sure that it works for all kids in Colorado. And so, again, without any firm commitments, this is definitely the way we're moving, and I would imagine within the next calendar year.
Thank you very much for that question, Jamie. Very, very much appreciate people speaking up and asking questions. Again, as Matt and others have said, it's this input that makes our rules better. And particularly for the new areas, I think we're meeting the minimums, but it's through this interactive process that the rules can grow and improve. Marina, other questions?
I do not have any other questions.
All right, Matt, I think you got off the hook relatively unscathed. With that, questions that folks have about the entirety of the presentation, things that maybe you thought, oh, I meant to ask that during a previous section, please do that now. And while folks are thinking about that, I also wonder if we should go to any of the questions that we got when people registered. There was an option during that registration to pose questions there. And so if Kristen or Marina, you want to go to ones that you think maybe we didn't answer during the presentation, I think that would be a good use of time.
Thanks, Tom. I wonder if Kristen has the form handy to pull up the question.
Yes, thanks, Tom. There was a general question related to Chapter 12 CSN service requirements related to crisis and certificate of compliance requirements. So I wonder if you speak more.
Thank you for that. And I see that that was from Nancy, and as always, Nancy, happy to talk with you about this at any point. But we do intend, and this was our proposed regulatory change, that we removed that COC requirement from Chapter 12. We think that that cleans up a lot of administrative burden. Now, that isn't perhaps as 100% great news as it may sound on the surface, because comprehensive service providers and some essential safety net providers are also going to have a behavioral health entity license. And that BHE license is really what that certificate of compliance is going to attach to now. So, but we did some statutory digging and realized that it's really the BHE portion, the behavioral health entity license portion, that that certificate of compliance really attaches to. So that's why we cleaned that up there. Additional nuance, I'm happy to discuss with you, Nancy, if you do happen to be on this call. Great question. What else?
Tom, will critical incidents involving personnel have the same reporting timeline?
At this point, our intent, yes. Now, I'd be happy to discuss additional nuance there and to see if there is a need for perhaps 2 levels of timelines. Now, I think our base question always when we get questions about requirements that impact health, safety, welfare, and I would say that critical incident reporting falls squarely in that category, is what are the effects on the person receiving services? So in further discussion about changing that particular requirement, that's definitely going to be a main part of that conversation. So short answer, no, at least for now, happy to engage in further conversation.
And Tom, I also want to ask what BHA is doing to minimize administrative burden through these rules.
Thank you for that, Kristen, and thanks to the person that asked that question. I don't mean to imply that what we consider improvements when it comes to administrative burden were fully addressed, 100% improved with the additions, deletions, and modifications that we rolled out today, particularly when it comes to provider rules. But I do sincerely hope that what we talked about does make a positive impact. I think that's been, particularly for me, having joined BHA in 2019, has been a constant thread of conversation, an important conversation, and I believe that we have been responsive. And if anyone thinks that there are additional areas that we should consider, I want to engage in that conversation. 2 more points. Something that doesn't exist in a rule that we also recently made a change about, and probably the number one thing that we heard from licensed, designated, and approved providers was about policies and procedures. Not necessarily writing them, though that is time consuming and burdensome, but in particular, needing to upload those policies and procedures. Just a tiny bit of background, policies and procedures that are written for the license designation or approval type that the agency in question is seeking. But to upload those into ladders and do so in a form and matter that works with our less than ideal licensing system has been the single biggest area of administrative burden for years. And a few months ago, we said we want to trial in a period of time where initial applicants and renewing applicants, those licensed, designated, and approved providers, do not have to upload those policies and procedures into ladders. Now, that doesn't mean that they don't have to be written. We still expect policies and procedures to be written. We expect that they demonstrate the agency's understanding and requirements of that particular rule, but we won't view them through ladders when we come out for an initial, a renewal, or an investigatory visit. When we talk with you about our technical assistance, we will look at the policies and procedures then. So we hope that that in particular is a significant reduction in administrative burden. The last thing on this particular topic is that we restarted an administrative burden work group. This is a chance for providers to work directly with us to talk about what those areas of administrative burden are. And we attempt as much as possible in this group to say, you identify the categories, let's break into subgroups and have you, with our involvement, of course, talk about and generate solutions for reducing that administrative burden. And by the way, that policy and procedure change that I just talked about was really a function of that administrative burden work group. So we hope, and I very much hope, that what we laid out today and those additional changes gets to a reduction in administrative burden. So thank you for letting me go on a little bit about that. We obviously spent a lot of time thinking about that here at BHA. Other questions we should cover that were part of the registration process?
Tom, I wonder if you could comment just generally how we are going to review feedback and how it's being considered in further updates to the rule.
Thank you for that question. Yes, an important part that demonstrates our commitment to carefully consider this feedback from our community partners. Every single comment that we get, every single written piece of testimony, we keep track of. That's part of why we record these. We record the chats, and we write those questions in alignment with the rule that we're considering change for, and then discuss internally whether we can make that kind of change. We provide an answer for every single question that we get, and then all of that testimony, and in this case, we're talking about everything we get from the links that we provided earlier in the presentation to our virtual and in-person meetings. And then finally, when we go to the state board or commissioner rule hearings, all of that becomes part of the formal record. And we bundle that and turn that in when we present to the commissioner or the State Board of Human Services. And we say all the engagement that we've done and what changes we've made and why, and what changes we haven't made and why for every single one of those. So that's our commitment to incorporating what we hear and what you tell us through all of these forums. It is absolutely critical. And again, I wholeheartedly want to remind everybody that part of why the rules exist the way they do right now was because of 18 months of your commitment with us to develop the provider rules. And that's why we're back asking you questions again. And a lot of what I went over earlier in specifically in provider rules is as a result of your feedback. So thank you for that question. I also want to make sure that my co-presenters have an opportunity to weigh in on any of these excellent questions we're getting. So if you think there's something I messed up or something that you would like to add, please stop me from talking and weigh in.
As Tom had mentioned earlier, there are other rule feedback opportunities. It's going to be a similar presentation throughout. I think depending on what questions look like, if you have questions that come to mind after this, there are different formats to also get that to us, whether it's the provide the written feedback form piece, as well as attending other meetings. We are going up to Grand County tomorrow for our first in-person. So I'm excited to get out in the community and also present rules, as I'm big on rules. So, but yeah, thanks for your participation in this, and look forward to continuing to kind of refine these drafts to get them to a good spot. So when we have our state board and commissioner rule hearings, that they are in the best shape possible with full engagement from community on those as well.
And I only have to add, thank you for taking the time to commit to reviewing these rules and commenting on them. Greatly appreciate it. The experience is not the same without that input. So thank you.
I know Ryan Mueller agrees. I think that we had in the chat, but just to say it out loud also, again, we intend to post the recording of this and the slides. I meant to mention that after Ryan Mueller's excellent, but also, as he pointed out, slides with a lot of dense material. I think that those slides in particular can serve as reference. I almost think about that as like a guiding document. So I think it'll be very helpful to have that in particular in your hands, and we endeavor to get that posted. Any other questions that have come up ad hoc or anything else that we should go to from the registrants' questions posed?
Yes, thank you, Tom. This is Marina. I got a chat just saying that a participant wasn't able to copy the link. So I asked for an email address. I'd be happy to send over some of those links. So if you're having some difficulties copying the links, please drop me an email here and I will happily email that over. Thank you.
Perfect, Marina. Thank you for that assistance. Well, it sounds like maybe that's it for right now in terms of questions. I would like to say on behalf of Behavioral Health Administration, thank you very much for your engagement. Hope we see you at upcoming sessions. And if not, I hope that you spread the word and share with people, family, other providers that you know to please come and help us make these better rule volumes. And looking forward to seeing all of you and reading your written feedback in the near future. Thank you very much for your time.